Hey everyone, thank you for joining me today for this training video on drowning incidents. My name's Harrison and I'll be guiding you through this video as we discuss the importance of these types of calls. As EMTs, understanding the nuances of drowning incidents is vital to enhancing your response and ultimately saving lives. Before we dive into the details, I'd like to introduce you to a key reference for our discussion today, Dr. Seth Hawkins. Dr. Hawkins is a renowned emergency physician, paramedic, and wilderness medical expert from right here in the Triad. His extensive work in emergency and wilderness medicine, particularly in innovative medical education, has significantly contributed to our understanding of drowning incidents. Dr. Hawkins' insights and research will be instrumental as we explore this topic. Drowning is a major cause of accidental death, affecting individuals across all age groups and backgrounds. Now, using numbers from 2020, worldwide drowning accounts for over 370,000 deaths annually and is the leading cause of injury and death amongst children under 15 years of age. In the United States alone, there are more than 500,000 drowning events each year, resulting in approximately 1,100 deaths. This makes drowning the second leading cause of unintentional death for individuals from birth to 19 years old. The majority of victims survive submersion events, with outcomes ranging from minimal or transient injury to profound neurological damage. Drowning incidents peak in 3 distinct age groups. The highest incidence occurs in children under 5 years old, primarily due to falls into swimming pools, open water, bathtubs, and even buckets at home. It's essential for us to consider intentional drowning in this age group and look for signs of child abuse. Now, the second peak age group is going to be found from the ages of 15 to 24 years. In this age group, factors such as suicide, homicide, domestic violence, and the influence of alcohol or drugs play significant roles. The elderly, who represent the third peak group, are at an increased risk of drowning, especially in bathtubs, often due to comorbidities or the effects of medications or physical disability. Even in coastal areas, most drownings occur in warm, freshwater bodies, particularly swimming pools, rather than the ocean. The warmer the water, the easier it is to drown. If you've ever swam close to the dam at Blues Creek, you know how fast your body can become exhausted in that hot water. Now let's proceed on into the next section to deepen our understanding and enhance our capabilities for drowning patients. Now that we have an understanding of the statistics and demographics related to drowning, let's delve a little bit deeper into what drowning actually is. Drowning is defined as experiencing respiratory impairment from submersion or immersion in a liquid. This impairment can range from mild difficulty breathing to complete cessation of your respiratory drive, which can lead to fatal outcomes if not promptly addressed. So, submersion refers to being underwater, completely or partially, such that the airways are below the surface of that water. Now, immersion refers to being in water, where the airways might not necessarily be below the surface, but water exposure leads to respiratory impairment. Simply put, drowning is a process with 3 possible outcomes. The first is death. The second is survival with brain damage, and the third is survival without brain damage. So therefore, drowning incidents can be classified as either fatal or non-fatal. Fatal drownings result in death due to respiratory impairment caused by the submersion or immersion in water. Non-fatal drowning refers to survival after submersion or immersion, but the individual experiences varying degrees of injury, which can range from no symptoms to severe and permanent neurological impairment. There's a common misconception known as dry drowning. This was popular in the media several years ago. However, the medical community has clarified that dry drowning is not a distinct condition and should not be used as a term. The confusion arises because some people believe that water doesn't need to enter the lungs for drowning to occur. The reality is that drowning always involves respiratory impairment due to water exposure. Here's what you need to know. Drowning can cause laryngospasms, where the vocal cords close to prevent water from entering the lungs. but this can still lead to severe respiratory distress and hypoxia. The emphasis should be made on the immediate management and resuscitation of individuals who have experienced any form of submersion or immersion, as prompt and appropriate intervention is critical to survival, especially minimizing brain injury. Think of it like this. If water enters into your upper airway during a submersion or immersion event, your body has natural processes that it uses to prevent that water from getting into the lungs. That can mean the epiglottis swelling shut, laryngospasms, varying different processes to prevent the water from entering your lungs. Now, you can still have intense respiratory difficulty and even death due to that simple protection mechanism that your body has. Nevertheless, it was a submersion or immersion event that caused this reaction. Thus, it is a drowning event, whether it be a fatal drowning or non-fatal drowning, depending on the patient's disposition. These definitions will help us understand the foundation of knowledge that's required to mitigate these incidents, and it's going to help us understand the pathophysiologies more when we go to discuss that shortly. But first, let's take a look at why some people are drowning in the first place. All right, now that we've covered the basics and definitions related to drowning, let's talk about the actual act of drowning and what it can typically look like. Contrary to how it is often depicted in movies, the act of drowning often goes unnoticed. It's usually silent and quick, which is why it's crucial for us as first responders to understand and recognize these signs. There are 3 primary actions or body positions that people adopt when confronted with the possibility of drowning. These stages depend on the individual's swimming ability, presence of injuries, or any underlying illnesses. Some individuals may progress through all 3 stages, while others may not. Those who have some swimming ability or possibly aided by a flotation device often call for help and are able to actively participate in their rescue. They may be in the vertical position treading water or horizontally actively swimming. These individuals are more likely to be visible and vocal, making it easier for rescuers to identify and assist them. We have those who are unable to help themselves assume a vertical position in the water with their arms flailing laterally in an attempt to keep their head above the surface of the water. Most do not kick with their legs. They will alternatively sink below the surface of the water and then reappear. Their mouths are not above the surface long enough for them to speak or breathe, and they will quickly sink, usually within 30 to 60 seconds. These individuals are unable to wave, call for help, or aid in their own rescue. Those who are unresponsive tend to float on or just below the surface of the water. This can include individuals who are already unconscious due to water inhalation or other factors like hypothermia or perhaps spinal injury. These victims require immediate and often more complex rescue efforts. In all cases of drowning, the victim is submerged under or immersed in water and requires rescue and medical assistance. Not all drowning victims are unresponsive during their rescue. They may be awake, able to respond to voices or react to pain. Recognizing the subtle and often silent signs of drowning is essential for effective intervention and rescue. Now let's move on to some video examples that illustrate these different stages of drowning. All right, in this next video, I'm going to show you a wave pool, and I want you to try to find the person who is drowning before the lifeguard does. Did you see him before she did? Let's go back and let's see exactly how long he was drowning before the lifeguard saw him. Okay, so in 18.28 seconds of active drowning, the lifeguard was able to stop the process and get his head and his upper airway above the surface of the water. That 18 seconds must have felt like an eternity to that young man, and it seemed like a really long time watching it back, just focusing on him. A lot can happen in that short amount of time when it comes to the amount of water that he is ingesting. He is in what I described as was that instinctive drowning position where he is just bobbing up and down, terrified and trying to just keep his head above water and gasping for air, but instead he's flailing his arms laterally. Let's take a look at another example. So here you see him go in and he instinctively starts flailing his arms laterally and bobbing up and down, trying to gasp for air. During this process, you can see how it very quickly slows from the instinctive drowning position into the unresponsive drowning patient. Here's one more to look at. So now that we've seen how quickly drowning can occur, and even in the presence of alert and attentive lifeguards, there is still enough time to cause major injury to the airway system. Now that we've seen and understand this, let's talk about the actual pathophysiology of fatal and non-fatal drownings. In this section, we're going to be discussing the pathophysiology of both fatal and non-fatal drownings. We're going to cover what happens inside the body during these events, some long-term effects, some specific conditions that can appear afterwards, and also the body's production of foam. When a person is submerged or immersed in water, the initial physiological response is for that person to hold their breath. If the person can't be rescued or self-rescue promptly, they will eventually gasp for air, subsequently inhaling water into their airways. This leads to several critical changes. Water entering the airway leads to a reflex response of coughing, which causes more aspiration. The presence of water in the lungs disrupts normal gas exchange. Due to this disruption, oxygen exchange is impaired and leads to hypoxemia or low blood oxygen levels. This hypoxic state affects all the organs, but particularly the brain, the heart. Where the brain's concerned, it's highly sensitive to oxygen deprivation. This status can cause rapid loss of consciousness and, if prolonged, irreversible brain damage. Cerebral hypoxia also leads to the cessation of effective respiration. Cardiovascularly, there's an increase in heart rate initially as the body attempts to compensate for the lack of oxygen. However, persistent hypoxia leads to bradycardia and eventually cardiac arrest. Here's an image that pulls all of this together. When the respiratory drive is impaired, hypoxemia occurs. This causes the circulatory system to fail to deliver oxygen to the brain. From there, the nervous system continues to fail, effectively stopping the signal from the brain to the body to actually breathe. Let's look at how to assess this type of respiratory impairment. Look at the breathing patterns. They are irregular or labored, gasping, or apneic. Several lung sounds may be present, either a productive or non-productive cough, wheezing, rales, bronchi, stridor. Utilize your oxygen saturation devices. Values below 94% indicate hypoxemia, and below 90% indicates significant hypoxemia. Look for other objective signs as well, though. Cyanosis. You may see the bluish discoloration, especially around the lips, face, fingers, toes. These are all indicating those low oxygen levels. Additionally, assess the consciousness. Are they confused, agitated, or unconscious? Long-term effects of non-fatal drownings can be in a wide range. From nothing to significant hypoxic brain injury can result in cognitive impairments, motor deficits, and in some cases, coma. Other survivors may develop acute respiratory distress syndrome, pneumonia, or other pulmonary complications due to the damage and inflammation now found within their lungs. The psychological impact is also significant, with increased cases of PTSD, anxiety, and generalized depression being noted throughout non-fatal drowning survivors. One specific condition that I'd like to talk about is severe acute respiratory distress syndrome, or SARS. Now, this is a severe form of that acute respiratory distress syndrome that develops following drowning. It's characterized by widespread inflammation inside the lungs and severe impairment in oxygenation. Simply put, it is the acute onset of respiratory failure. Fluid buildup in both lungs can be seen on a chest scan, and severe hypoxemia that is not fully explained by a previous cardiac failure or just fluid overload will develop. Symptoms typically appear within 6 hours to even a few days after the event. In SARS, the aspiration of water causes direct injury to the alveolar capillary membrane. This leads to increased permeability and fluid leakage into the alveoli. What does this mean? It just means it's widespread pulmonary edema, reduced lung compliance, and impaired gas exchange. One of the best treatments for SARS, especially if you're having to provide artificial respirations, is PEEP. Positive end expiratory pressure is crucial in managing this. It helps keep the alveoli open during exhalation, improves oxygenation, and prevents alveolar collapse. The initial PEEP setting should be at 5 centimeters of water and increase based on the patient's response. Proper PEEP settings were going to help ensure that oxygen levels in the blood are sufficient and that the amount of unoxygenated blood bypassing the lungs is kept low. These are the PEEP devices that we have inside of our small adult and pediatric BVMs, the bags with the yellow stripes. There's going to be some instructions that you can find through the manufacturer's website, and even in the bags if they were able to keep the book inside of there whenever you got it. Take these out, take a look at them, see where they go onto the BVM and how to set them, as this is going to be a critical tool with drowning patients. The last thing that I'd like to talk about is foam production. It's important to understand this phenomenon, specifically because it has significant implications for the treatment and prognosis of drowning victims. When water enters the victim's mouth and nose, the body's immediate response is to protect the airways. We've talked about this. So the epiglottis closes over the trachea, or the laryngospasm occurs. The victim is going to reflexively swallow water down into their stomach to prevent large volumes of water from entering their lungs. Despite this protective mechanism, water can still be aspirated. We know lungs are composed of numerous small air sacs where this gas exchange occurs. There's 2 types of cells inside of the alveoli. Type 1 cells are curved and comprise the majority of the surface area of each alveolar sac, and this is where the actual gas exchange occurs. Type 2 cells, they're squarish, and they secrete surfactant, which is going to cover the interior surface of each alveolus. Surfactant lowers the surface tension of the air-alveolar interface, and that's going to prevent the alveolar sac from collapsing at the end of each exhalation. Contrary to popular belief, very little water is going to enter the lungs of most drowning victims, especially the ones that we are able to promptly rescue and start providing care to. Non-fatal drowning patients aspirate less than 1 ounce of water. During autopsies of fatal drowning patients, only 1 to 2 milliliters per kilogram of water is typically found inside the lungs. So this means for a 200-pound patient, that's about 90 to 180 milliliters, or 3 ounces to 6 ounces of water. Even this limited amount of aspirated water can cause SARS or even death. Pathophysiology of foam production is going to involve several steps. First, the aspirated water is going to irritate the lining of the lower airway. It's going to cause inflammation, bronchial constriction, very similar to asthma, and you may hear the wheezing associated with that. This water is going to disrupt and wash out the surfactant that's produced by the type 2 alveolar cells. Without the surfactant, the surface tension within the alveoli increases, leading to alveolar collapse and impaired gas exchange. Additionally, these cells inside of the alveoli enter into a self-disruption phase, which is going to release even more surfactant and plasma back into the lungs and the lower airways. As this surfactant mixes with the leaked plasma, coupled with the air moving through the lungs, especially due to our interventions, foam is created. The foam can issue from the patient's mouth and nose, and it makes resuscitation efforts more challenging. Anticipate this foam. Additionally, vomit and water. It's critical to continue breathing through the foam and suction only vomit or water to maintain this airway. Do not attempt to suction the foam. The stomach will become distended with water intake as well as air and more foam. Here's an image of a fatal drowning showing the stomach contents. I'd like you to notice here the different layers that have been identified through this scan of the stomach contents. We are wanting to target any water or debris inside the stomach that comes back up to be suctioned. The foam will not allow us to suction it. It is more air than anything else. It can be extremely thick or it can be very bubbly. Regardless, our suction devices are not going to work well. Breathe through the foam. Do not attempt to fight it. You will be shocked at how much foam can come out of these patients. With that being said, let's take a look at a couple videos that shows you just that. Okay, I want you to watch closely. They are inserting an OPA into this drowning victim. They've been doing CPR on him for a little bit. It took him a second to get the appropriate supplies over there to put the OPA in. Once it zooms in, watch, and you're going to see the foam start pouring out of his mouth. And then I'm going to try to freeze frame it on a couple spots to where you can see it coming through the OPA.
15, 16, 17, 18, 19, 20, 1, 2, 3, 4, 5, 6, 7.
So here you can see some of it, and there's another shot of it as it is just coming straight out of that OPA. This is actually not a lot of foam. There can be a lot more. I'm going to show you one other video. Unfortunately, there's not a lot of videos of real patients that's showing this. This next one may be triggering, but it is the best representation that I can give you so you can know what to expect. Please understand that even here in America, some people believe that the Heimlich maneuver or picking someone up by their feet and shaking them is appropriate and effective treatment for drowning. I can assure you it is not, but you're going to see that here in this video. I want you to focus on the foam, how thick it is, and how much of it there is. Again, this foam cannot be suctioned. Multiple studies have shown that while respirations and delivered oxygen may be slightly impaired whenever you're bagging through the foam, it is nothing compared to the damage done by trying to remove the foam that is going to continuously come. All right, the last thing that I want to touch on for this video is just a quick protocol review. I've already talked a lot about various different terms and processes and skills that you see on this sheet, so I just want to bring it all together here, right? So we're going to start off looking at history. Submersion in water, doesn't matter about the depth. Think about any potential trauma that may be happening. How long was the submersion or immersion? What was the temperature of the water? All of these things matter. Remember that we do CPR until the person is warm and dead. So in the presence of hypothermia, you will always do CPR. Looking at signs and symptoms, unresponsive, mental status, vital signs, all of these are going to tell you the status of the patient. And remember, just because you pull someone out and they're breathing okay right now, within a few minutes to a few hours or even a few days, severe complications can occur. Look for the foaming, the vomiting, coughing, wheezing, the other lung sounds that we talked about. So now looking at the different types of patients that we can see, we're going to start with the awake and the alert, right? We're going to give them some oxygen. Think about any spinal immobilization needs, remove wet clothes, treat for shock, basically, right? Then we're going to monitor and reassess constantly. We need to encourage transport. Main reason is that they need to get a CT scan, see if they're starting to develop that SARDS. Now let's talk about awake but with an altered mental status. The one big deviation that you're going to see with resuscitation efforts in the drowning protocol compared to the others is that we're always going to start 5 breaths via bag valve mask. They will tolerate this if they have an altered mental status. This is very important. Remember, this event is caused due to a massive acute respiratory failure. They need oxygen first, not compressions. Maintain the airway as deemed appropriate by the patient's condition. This can be a NPA, OPA, iGel, whatever they'll tolerate, give it to them. Be sure to treat for shock and continuously monitor, as this may very well evolve into an unresponsive patient. Now, if you do find this patient, they're unresponsive, we again, 5 breaths via BVM. They have a pulse, we're going to go right back to that stabilized treat for shock. If not, we're going to go right into regular CPR. Understanding, though, that if this foam occurs, we're going to bag through the foam. Don't try to suction it out. Only suction out vomit and water that may be coming from the stomach distension that occurs with drowning. I hope you were able to learn at least a couple things new about drowning patients, maybe some new terminology, new treatment, or just refresh some skills that you already had. Regardless, thank you for watching this. I hope that nobody has to come across these patients this summer. If you do, you're going to do great at managing this call. Have a good one. Be safe.